The Uganda we want. So mu Uganda gye twagala mu lutalo luno olw'okulwanyisa obulabbayo obukenuzi nze kyempita obuvundu. Munna Uganda alina okuba nga yeenyigiramu.
Ffenna twenyigire mu lutalo.
Ate abalala tebasomye kuzimba wabula bayize okuzimba.
Uganda gye twagala okulaba ng'enguudo zonna nkole nungi, public transport nga weeri.
Kati eno gavumenti eriwo erina akabonero ka Lucifer. Buli kyotunulako mu Uganda kiriko oxygen. Either babika amawulire malungi oba mawulire mabi. Minisita teyeetaagisa kabangali budde buno zaaki.
At this time, why should somebody import furniture from outside Uganda? Let us leave NRM to be in charge for another 36 years or more.
I really want to see a Uganda that believes in the rule of law. If you have a constitution in place, follow it to the letter. Don't change laws just because you want them to favor you.
Kuba njagala omanye nti obugagga bwonna Uganda bwe yeeyagaliramu buyita waffe ku ttaka lyaffe. Naye busoga mugidibaze.
How can a referral hospital refer you to a private clinic? The Uganda we want buli muntu ateekwa okumanya nti I am a stakeholder, nkwatibwako si kwesuulirayo gwa naggamba.
Uganda oyinza okukakana nga mwe mulina bagraduates aba university nga bangi okusinga ebungereza. Mwe mufokasinga nnyo ku degree. Eri bo bafokasinga nnyo nti byensomye mbijjeemu omulimu n'enkola.
We are dreaming of a Uganda where at a young age there is such a relationship between parent and son, parent and daughter, where the daughter can say this is what I want.
Uganda gye twagala empya tesobola kubeerawo nga tewali mateeka. Amateeka agakola.
The Uganda we want. Welcome to the program, The Uganda We Want. My name is Mulanzi. I'm so happy and honored to be back here on this show to share with you and also to host our guest in the program, The Uganda We Want tonight. Our viewers on Dream TV, our viewers on BTV, and our listeners on Impact FM and all other social media platforms. Thank you so much for following this program. You can continue to watch this program even after it has been aired on your screen, on YouTube, at the Uganda We Want, and at Dream TV Uganda. You can as well follow the discussion on X, on Instagram, and as well Facebook. So please make sure that you're with us. We as well have another channel where you can be able to view and listening to Impact FM on an app called Doxa. So if you have a smartphone, you can download a Doxa app. If you're on Android or on Apple, you can as well have that app. It will be good for you. It is very convenient wherever you are. You're able to watch us. Well, today we host Dr. Daniel Byabakama. Dr. Daniel Byabakama, he's the head HIV Prevention, Uganda AIDS Commission. Doctor, we are so honored to have you on the program. Could you please greet our viewers and our listeners?
Good afternoon, our listeners. I'm glad to be here to talk to our listeners about our work in the HIV response.
Yeah, well, you know, it could be that someone is watching us or listening to us for the first time. He doesn't know who is Dr. Daniel Byabakama. Could you just take us through and we get to know this doctor who is going to speak to us?
Yes, so I am Dr. Daniel Byabakama. I work at the Uganda AIDS Commission as the head of the HIV prevention program. And the Uganda AIDS Commission, we are a government agency under the Office of the President. Our mandate is to coordinate all the HIV stakeholders in the national HIV response across the country. including ministries of government, including religious institutions, including cultural institutions, including donors. So everybody who has something to do in the HIV response must be guided and held accountable by the Uganda AIDS Commission to make sure we are shooting in one goal. We are all on one message. We are all implementing the same strategy. The temptation for people to implement their own strategies is always there. Of people to advance non-evidence-based opinions and interventions. So they need somebody who checks to make sure they are told that is not in line with the national strategy. There are so many people with hypotheses on what HIV, what the problem is, how can we end HIV. Some of them which can be detrimental. So the Uganda AIDS Commission is to make sure everybody's effort does not sabotage any other person's effort, and we all speak one language, one strategy, and that's why there's a commission. So when the HIV response started long ago in the 1980s, it was initially managed as pure as a medical problem, as a health problem, like other disease. But it later was discovered that HIV is not just an ordinary disease to be managed pure in the hospital. Its determinants, what influences its spread, it's the vulnerability of people are way beyond the scope of the health sector. It needed religious leaders to play a part. It has an element of culture, some cultural practices that put people at risk. It needed the agriculture sector to do something to make sure we fight together the epidemic. So that's when they constituted the Uganda AIDS Commission to coordinate all the stakeholders.
So you come up with the policy
Yes,
that
absolutely.
all these other stakeholders
subscribe
to. Okay. Oh. Well, Doctor, we are going to come to the message and the strategy and the policies. I know we are going to reach that. But before, I'm still interested in knowing Dr. Daniel Byabakama. Yes, I know now that he does work at the Uganda AIDS Commission. But before he came to the Uganda AIDS Commission, he might have went through school, he might have gone through university, and he hasn't told me that. And probably your teachers could be watching. It would be good if they can, as well.
So you want my life story?
Yeah, briefly, just briefly. You can just let us know you went to the school, then from there, I don't think you earned this title of doctor just by waking up and you're called doctor. You might have struggled and, spent sleepless nights.
Yes, of course. So as a doctor, I went to Makerere University. So I studied a degree in medicine from Makerere University. And I later studied a master's degree in public health from a university. It's called the University of Melbourne. It's in Australia. And I have been working with the Uganda AIDS Commission for 8 years now.
8 years.
So I have been here for quite some time. So where I attended primary school, secondary school, that is...
It is relevant, but it's okay if you feel uncomfortable saying so. So are you from the east, west, central, north?
Yeah, I come from Ankole.
Uh-huh.
I come from Mbara district.
Mbara district, yeah.
And so part of my school was done at Intare School for my O-level. And then I joined the King's College Budo for my A-level. So from where I joined Makerere University to do a degree in medicine. And I proceeded to do a master's in public health from Australia at a university called the University of Melbourne.
Wow, if we are doing this show in Nyankola, I would say Ruhanga ya Chikora.
Absolutely.
Well, it's good to have you, Doctor. Now, back to the Uganda AIDS Commission. Yes, you've tried to elaborate to us that you're mandated by the constitution of this country, but you've been so fast. We would like to know, because someone would be asking, okay, we hear of Uganda AIDS Commission by law. What are their functions, in case if you can remember one or two, probably to be more specific? What are your functions?
We are mandated to deliver a clear mandate. The first one, of course, is setting a national strategy.
Setting a national strategy.
A national strategy for the HIV response. So we are the custodian of the national HIV and AIDS strategic plan, the framework that guides everybody in the national HIV response. So if you are implementing outside that framework, you are not implementing what is approved by government.
By example, if I come up with a campaign as well to end HIV, I have to be sure that it is in
aligned
line or is aligned
with that strategy. So we are the custodians of that national overarching strategy. I think the second part of our mandate is about advocacy. So we did an advocacy and sharing information. So we engage various media houses, various media channels to make sure the message is taken out to the people, that they are reminded that HIV is still a problem, and they're educated on what they need to do to participate in the fight against HIV. I think the third part of our mandate is in resource mobilization. We must lead in raising the resources for the HIV response. So both in articulating the need that is supported by government, but also there are also initiatives like the Global Fund, international opportunities for raising that are available to make resources available for the national HIV response. So it's our mandate to make sure the HIV response is well resourced and to achieve the goal of ending AIDS as a public health threat as it is now. I think the other part of our mandate is in research. To coordinate researchers, we don't implement researchers, but we have a research agenda. So we put together a national HIV and AIDS research agenda to guide researchers out there and to coordinate the researchers out there to make sure the key questions that we need answered so that we advance the HIV response are prioritized by researchers. So we coordinate HIV AIDS research by creating the research agenda and guiding the researchers on where to put the focus in the HIV response. Of course, the other key response is synthesis of data, generation of information. Every year we collect data on how we are performing. Every year we disseminate data, that is information. How many people contracted HIV last year, for example? We know, it's our mandate. Of the people who contracted HIV, how many were young people? How many were old people? So that we can always guide our stakeholders on where to put the effort, where to put the limited resources so that we can have maximum impact. So we generate the data through, of course, conducting special surveys, special studies, so that our stakeholders, the community-based organizations in Kabari, we can easily guide them that right now, the highest number of new HIV infections are occurring among adolescent girls. Put the limited resources there. That's where you'll have maximum impact. So that's our role, to make sure we generate data, we generate information, and we guide stakeholders to make sure they are not wasting the efforts, they are not wasting the resources. All our efforts are well targeted towards the goal of ending AIDS as a public health threat.
Yeah, Doctor, taking you back to the third point or function that you mandated as Uganda AIDS Commission of resource mobilization. I think you're aware, news came to you. For us, news met us when others were walking, as we were sitting in their rooms and others. But globally, you know, especially one of our key donors, US came up and said, we are going to stop this funding. Now, as a commission, what steps are you now undertaking to see that people that have been supported are going to continue to be supported? How are you going to mobilize resources to maintain that? Because people already started crying and say, now I think we are done.
I think people need not cry. Okay. I need to start from that point because the president of Uganda has on several occasions reassured the people that whether donors stay or they go, he will make sure, most especially people living with HIV, they get the services they need. You see, the HIV epidemic is a unique epidemic. If we removed the foot from the pedal right now, if we stopped the funding, if we stopped the interventions we are implementing now, we shall get into reversal. The number of people dying from AIDS will increase. The number of people contracting HIV will increase. So we cannot make that mistake. And I trust our head of state. He has on many occasions categorically said, if the donors leave, because this is not the first time, they had all along been threatening to leave. So I don't think it comes to a surprise to our leaders that they have left. They had all along been threatening to leave. And now, as the Uganda AIDS Commission, who are the leaders of the response, in preparation for that departure, they had warned us they would depart. We had started working on a sustainability roadmap to see what we need to do as a country to take our full responsibility for the HIV response. This sustainability roadmap, by the time the US government announced their cuts in funds available to our response, it was almost in the final stages. So what we are doing as the Uganda AIDS Commission, we are fast-tracking, completing that sustainability roadmap. We take it to cabinet. Sustainability roadmap has financial implications, but our preliminary conversations with the legislators and cabinet members is that they are committed to funding the response, to finding the resources to fund the response.
Yeah, for purposes of being assured that yes, USC is doing something, what is in the sustainability roadmap? What is in there? What is entailed there?
So in the sustainability roadmap, of course, number one, it shows how much money the government of Uganda has to increase. The government of Uganda is already funding a significant proportion of the response. So in the sustainability roadmap, it already shows how much money, how much more money the government of Uganda, how they will fill the gap, what gap needs to be filled. It also shows the efficiency for us to implement the HIV response within our means. We are not a very rich country. That one we must be honest. That we are not as rich. We don't have a vast resource envelope like any of these developed countries like America. So for us, we must implement a program that is within our means. So for us to implement within our means, we must also aim to minimize wastage. So a key component of the sustainability roadmap looks at efficiency. How do we increase efficiency? How would we minimize wastage? So one of the key strategies, for example, which we have already started rolling out immediately, is integration of services for quite a long time. And for justifiable reasons, the HIV program was a parallel program, was implemented as a parallel program. If you went to the HIV, to any hospital, there is an HIV wing, there is an HIV clinic, there's an HIV laboratory, there's an HIV doctor. But we know that was justified from the beginning because HIV was heavily stigmatized. A person who had HIV, if they visited the hospital, usually they would come when they are emaciated, when they are really pale. People would easily identify them that these people have HIV. And people would stigmatize them by simply walking away, for example. So we discovered for the dignity of our brothers and sisters who were already living with HIV, if we created safe spaces for them, they would come, pick their medication, be tested for HIV without being shamed and dehumanized. But we believe with our efforts now, the HIV stigma has significantly come down. we can fully integrate now. The HIV positive person can sit in the same line with a person with malaria and they're seen by the same doctor. So that instead of having two medical officers, one seeing the HIV patient, the other one seeing the malaria patient, one sees both of them. We believe the time has come. So that will significantly save on the cost of managing our HIV program. And we believe it will bring it within our means that the incremental budget support we expect from government would actually make a seamless transition, that our people shall not feel the pain of our donors, the US government departing. Fortunately, we had a good stock of drugs, so people let them rest assured. And fortunately, they're still around to support key components of the HIV treatment program, which is the most critical, the most critical. If people spend a week without medication, it creates a crisis. So we are guaranteed that we have enough stock of antiretroviral drugs in the country. And even though the US government has announced reduction in funding, they have retained support for essential commodities, especially for HIV treatment. So they're still here, yes, for treatment, laboratory services, to support the treatment, personnel to support the HIV treatment program. They are still here. But we are saying, in case you go, still we shall be prepared for the day you totally wash your hands and depart.
Doctor, talking of the drugs that you're saying are enough, okay? By the time this announcement came in, you're saying that we had enough drugs for those who are affected by HIV. But you know very well, sometimes what happens in our country, after some time you hear that this medicine has expired without being used. So in your sustainability roadmap, is there a way that you have maybe thought about it that, okay, we will not allow the drugs to expire before people use them?
Yes, of course. Of course, the expiry of drugs is a system issue, really. The quantification, the procurement system, so that we perfect the quantification. When you're bringing in the new drugs, the ones which are already in the country are almost getting finished, not to bring in too much stock that will stay in the stores for so long. But also, it's about the organization of the clinics. That a clinic which has more drugs than it may need, there's an arrangement to move those drugs. The clinic which has less drugs than it can consume. And in our integration plan, we have taken care of those, that the systems will have a way of communicating to move drugs between health facilities. But also we have perfected now our quantification and projection. If you see the number of people living with HIV now, is around 1.5 million people. And most of those people, we already know the HIV status. Most of those people are already on treatment, close to 1.3 million. So the number of people we are planning for doesn't change so much. So now we have a regular number. We have been in this business for a long time. So we know how to quantify, to make sure a certain lot of drugs is on its way. Some of it is already in our stores. Some of it is in the health facilities. So the expiry of drugs is no longer our major problem because we have trained enough manpower to manage the procurement system.
Yeah. Sorry, Doctor, that we have dragged so much on this, but I think it's very important for us for you to help us understand what you're trying to do to deal with this announcement of the US,
so
especially about funding.
The expiry of drugs and stockouts of drugs are a problem we have solved through capacity building. That we have enough people who know how to quantify and make good projections on the amounts we need, when we need them, how many should be in the store, how many should be on the ship coming. So we have perfected that.
Okay. Well, I know very well, and I think you also know, that one of the things that normally, talking about the system issue, some of the things that normally hurt Ugandans is when our government delays, when it's not supposed to delay. For example, you're talking of, okay, that you're going to be looking at, in your roadmap, you're going to be looking at the government, the executive to say they provide the funds to bridge the gap of the donors. But you know very well, sometimes you may make the request of that money and it delays. In the sustainability roadmap, how are you going to deal with that? Remember, when the government delays to release the funds, you know what's going to be happening to me who is affected with HIV.
I think the procurement...
It's a bit technical, but I don't know how you're dealing with that.
No, I hope the government, the Minister of Finance specifically, knows how to rank some of these issues. So I think it's an advocacy issue to make sure the Minister of Finance, because once the government has committed to fund the response, I think what remains is for the Minister of Finance to know, as it ranks its urgent issues, to know that the issue of HIV treatment is a high priority issue. When people get stuck out of drugs, the transmission of HIV increases. We have a bigger problem tomorrow than we have today. So I think it's through advocating with the Minister of Finance. I don't think there's a time when the government is completely bankrupt. No, it's an issue of priorities. So we hope that we shall advocate with our colleagues at the Ministry of Finance. Among the priorities they regard highly is HIV treatment for reasons we shall give them, including the risk of a bigger HIV burden, increased transmission once people are not adhering to treatment very well. So we hope the system will work well. And besides, we're about to start mining oil. So the money will not be the problem.
There's that hope. Okay, yeah. Let's hope that really that works out very well. And it's good to hear from the Uganda AIDS Commission that they have got, you know, a roadmap that is going to help us, because, you know, some of those that are affected or infected with HIV, they always have that fear that probably if now the US has already, you know, cut the funding, the donation, and we know what is happening in our country, especially the delays, as you said, very rare to our government to be completely bankrupt. But setting priorities and releasing the funds according to the priorities, that has been, you know, bringing fear within Uganda. But as we've heard from you, hopefully it will work out for the good of those that are being affected. So, Doctor, I want us to have to take a break, and I'll have you again tomorrow in the second episode. And the key question we are going to be talking about will be, is it possible to achieve a Uganda free from HIV or AIDS? And since you're the head of HIV prevention, why are we still talking about HIV or AIDS in our country? How can we really achieve that Uganda that is free from HIV or AIDS? When we return in the second episode with Dr. Daniel Byabakama, for now we sign up and say bye-bye. The Uganda we want. So mu Uganda gye twagala mu lutalo luno olw'okulwanyisa obulabbayo obukenuzi nze kyempita obuvundu. Munnayuganda alina okuba nga yeenyigiramu.
Ffenna twenyigire mu lutalo.
Ate abalala tebasomye kuzimba, wabula bayize okuzimba.
Uganda gye twagala okulaba ng'enguudo zonna nkole nungi, public transport nga weeri.
Kati eno gavumenti eriwo erina akabonero ka Lucifer. Buli kyotunulako mu Uganda kiriko oxygen. Either babika amawulire malungi oba mawulire mabi. Minisita teyeetaagisa kabangali budde buno. Zaki?
At this time, why should somebody import furniture from outside Uganda? Let us leave NRM to be in charge for another 36 years or more.
I really want to see a Uganda that believes in the rule of law. If you have a constitution in place, follow it to the letter. Don't change laws just because you want them to favor you.
Kuba njagala omanye nti obugagga bwonna Uganda bwe yeeyagaliramu buyita waffe ku ttaka lyaffe naye Busoga mugidibaze.
How can a referral hospital refer you to a private clinic? The Uganda we want buli muntu ateekwa okumanya nti I am a stakeholder nkwatibwako si kwesuulirayo gwannagamba.
Uganda oyinza okukakana nga mwe mulina bagraduates aba university nga bangi okusinga ebungereza mwe mufokasinga nnyo ku degree eri bo bafokasinga nnyo nti byensomye mbijeemu omulimu n'enkola.
We are dreaming of a Uganda where at a young age there is such a relationship between parent and son, parent and daughter, where the daughter can say this is what I want.
Uganda gye twagala empya tesobola kubeerawo nga tewali mateeka. Amateeka agakola.
The Uganda we want.